All right, so this is actually sort of I expanded upon a version of a talk I gave for one of the EF support groups. So, so we'll be talking about intractable epilepsy or treatment-resistant epilepsy today, and this is meant to be a short presentation. So then that way, there's time for questions at the end. There's not so many of us, so so feel free to participate. Okay, so. So I wanted to start with some definitions because you may not realize this, but we actually started to, we actually changed the definition recently of even how we define epilepsy. Because previously it was just defined as 2 or more unprovoked seizures, but that didn't account for the fact that sometimes kids would present with their first seizure, their EEG is consistent with an epilepsy syndrome, like absence epilepsy, for example. Or, you know, they have their first generalized tonic-clonic seizure and their EEG is consistent with juvenile myoclonic epilepsy, for example. So then why do you have to wait until they have their second seizure to define them as epilepsy? They should be defined right at that time. So they changed it to say you could have 1 unprovoked seizure with an EEG consistent with an epilepsy syndrome, and that alone is sufficient to make the diagnosis. And then within that, we also have a framework for how we classify the different kinds of epilepsies. So they're sort of stratified out into focal, generalized, or unknown. And we say unknown if we've never been able to catch a seizure on EEG, or if, you know, based on the description, we're not quite able to make it. And then you can then further stratify that into types of epilepsy. So focal, generalized, combined, or again, unknown. And then from there, you can define whether or not they have an epilepsy syndrome. Kind of overriding all of this, there's a lot of different comorbidities that happen with epilepsy. So things like learning disabilities and anxiety and depression. And then there's lots of different reasons why people have seizures in epilepsy, whether it's structural, genetic, infectious, metabolic, immune, or unknown. We're finding a lot of this unknown category probably is genetic. And as we're doing more genetic testing, we're finding more etiologies for epilepsy. So what is drug-resistant epilepsy or intractable epilepsy? So it's when you failed 2 or more appropriately selected and tolerated anti-seizure medications. So what does that mean? So appropriately selected means that you are being given the correct medication for the specific seizure type that you have or your syndrome. So if you have a generalized epilepsy and someone, you know, another neurologist didn't realize that and put you on a medication for focal epilepsy and your seizures got worse, then that is not the appropriate selected medication. So that's not considered a failure. That was not the correct medication to begin with. But if you have let's say you have absence epilepsy, you're on ethosuximide, you titrate that up and you continue to have seizures. Next, you go to lamotrigine, you titrate that up, you continue to have seizures at that point, and you're not discontinuing it because you have side effects. So it's just, you know, if you are titrating up lamotrigine and you develop a rash and you have to discontinue it for that reason, that's not considered a failure. That's just you had an allergic reaction to lamotrigine, so then you move on to another medication. Once that's titrated up into a therapeutic dose and you continue to have breakthrough seizures, that's then the definition of drug-resistant epilepsy or intractable epilepsy. So failing 2 or more medications that are appropriate for the seizure type and titrated up to an appropriate dose and not discontinued because of side effects. Okay, so hopefully that makes sense. All right, so sort of the original definition of this and who goes on to develop this came from this paper that was in the 90s of early identification of refractory epilepsy. So we always refer to Kwan and Brody, and you know, it's always nice to go to, when we go to American Epilepsy Society, if we walk around with Dr. Sankar enough, we get to meet some of these people. So it's like the neurology version of meeting celebrities. So they're still very active in the epilepsy world and are still around. But this was a seminal study that was done in the New England Journal. So they looked at all comers who had initial seizures, and what they found was 63% came under control with the first drug they tried. Of these, 470 had never received any seizure medication before. So about 64% of those became seizure-free with their first medication. And then 55% had received a seizure medication before. Maybe it wasn't, appropriately titrated, or maybe they didn't continue on it. Of those, 56% became seizure-free. If they then were not receiving any drugs at the last clinic visit, a lot of those became seizure-free. And then if they had one drug at the last at the last clinic visit, about more than 2/3 were seizure-free. So the problem is once you go up with the number of drugs that were needed, only 23% were seizure-free. If you were receiving 3 or more, then only 0%. So this is how we can kind of identify, if you come under control with the first drug, that's about 60 to 70%. And then that remainder percentage, those are the people that often will need to go on to have a second medication. Okay, but that article was published in 1998. So that was over 20 years ago. So what happens now? Because at that time, we really had very few medications. We had, Tegretol, Trileptal, Depakote, Phenobarb, and Keppra had just come on the market. Now we have so many different medications. So you would think, okay, well, now we have new technology. How has that changed? What they found is things didn't really change very much. So I'm not going to go over this whole table, but let me just tell you the percentage that became seizure-free at 1 year was about the same. It was 63.7%. So it might be a little bit disheartening to hear that, but at the same time, it makes you think, okay, well, this has something to do with the sort of the natural evolution of epilepsy, or why people have epilepsy in the first place. So what's next? So we recommend, after you fail 2 appropriately selected medications that haven't been discontinued due to side effects, you should really consider evaluation by an epileptologist. And you find that a lot of neurologists actually do have epilepsy training. So just because someone doesn't refer to themselves as a pediatric epileptologist doesn't mean they're not a pediatric epileptologist. So these are people like me who've undergone extra training in epilepsy and maybe even have board certifications in neurophysiology or epilepsy. So at that time, we can determine, were you on an appropriate medication? Was it discontinued for side effects? Do you meet definition of intractable epilepsy? I've had a few patients over the years that they came to me and I found out they were just on the wrong medication for their type of seizure, and just taking them off that medication, they became controlled. So they don't even meet the definition of intractable epilepsy. But let's say you get appropriate medications, they're selected, you still continue to have seizures. That's when we start thinking about other treatments to consider. And my colleagues have their own talks about each of these things. So I'm just going to go over them very briefly. So things to consider, of course, there's always more medications because we do have newer medications on the market. Even though it's diminishing returns as you fail medications, it's less likely that the next one will render you seizure-free. But you can start thinking about something like epilepsy surgery. It used to be something that was considered just for focal epilepsy, but we do have options even for generalized epilepsies. You can think about neurostimulation devices, so things like vagal nerve stimulator, responsive neurostimulation, and deep brain stimulation. And then there's ketogenic diet as well. So with epilepsy surgery, if you meet this definition of failing 2 or more anti-seizure drugs, you know that about 30% of those patients with epilepsy have inadequate control. So if you have something focal like a tumor, you have something else, you may actually need to go to surgery before you even meet this criteria. But in general, we refer patients who have medically refractory epilepsy. If you have a focal onset, then that's criteria to be evaluated. If you have a lesion, even if you don't have a lesion, there are some options for further studies that we could do beyond just MRI to look for a region or a focus for your epilepsy. And then finally, we had to make sure that after you have surgery, you have stable postoperative care. For kids, this isn't as much of an issue because they have parents to take care of them, but in adults, that can be an issue. Same thing with having controlled psychiatric comorbidities. So if somebody is extremely depressed, they have epilepsy surgery, become seizure-free, but then they commit suicide, that's not ideal in terms of their long-term care. So we have to make sure that they're going to be cared for and that their long-term care, we can actually improve their quality of life. And how we came about this, one of these there was a trial to kind of look at this that happened here at UCLA actually. And they looked at 38 patients who had refractory mesial temporal lobe epilepsy shortly after they failed 2 anti-epileptic drugs. 0 of those in the medical, they split them up into medical management, so more medicine versus going to surgery. And 0 out of 23 of the patients who just did medications were seizure-free versus 11 out of 15 in the surgical group. And they had an overall improvement in quality of life. However, this wasn't statistically significant. They did see some memory decline in a small subset of patients after surgery, but this was consistent with known rates after temporal lobectomy. So it just shows that this has a higher success rate than just pushing on with medications. It also is associated with lower healthcare costs in general. So if you look at over time, the cost of anti-epileptic drugs, the cost of hospitalizations for status, going to the emergency room, surgery actually is cheaper. And so insurance companies will cover this. But why do parents or patients not think about epilepsy surgery? The average patient actually waits up to 22 years between the onset of their epilepsy and surgical referral. That's a long time. And some of it may be because they're not diagnosed as having medically refractory epilepsy, or they're not recognized to have medically refractory epilepsy, or there's also a perception that it's drastic or a last resort. And this comes both on the part of the patient and the provider. So I've seen this before where, I'm giving a talk to general neurologists and someone said, oh, epilepsy surgery, that's really drastic, right? Like, I'm not going to send a patient to get part of their brain cut out. But in reality, if you talk to them about risk benefit, in terms of surgery versus not surgery, I think it's better for them to know what the options are than to withhold that option in the first place. In kids, we're much better about referring for surgery early, so the mean time is much shorter. This was also a study done by Christine Bauer-Baca here at UCLA, and if you have something like infantile spasms, which is a catastrophic epilepsy syndrome, you're more likely to be referred earlier. You're more likely to have a brain MRI. Unfortunately, we need to also work on who gets referred, because you were more likely to be referred if you had private insurance. However, interestingly, if you were Hispanic, you were also more likely to be referred. But some of that might be reflective of the patient population in Los Angeles. But it is something that we need to, of course, improve upon with access to care. So this is just an example of how the workup can be very different here at UCLA, because sometimes you do have an obvious lesion on the MRI or an obvious area of abnormality. But in addition, we do a PET scan and we fuse the MRI and the PET together to make this color image called a MRI PET fusion. And this goes, the analogy I say is like going from black and white TV to color TV. So you're getting a little bit of a better picture of what's going on here. So this is very subtle on the MRI. This shows up as a darker area on the PET fusion. Same thing here, you need a helpful arrow, even as a neurologist, to see that there's an abnormality here. This might be skipped over by a lot of people and not realizing that it's there. But when we then fuse it with the PET scan and get a color image, the areas that are not metabolizing the way that they should and potentially generating seizures are colder than the rest of the area. So these the red is sort of normal metabolizing, and then the green or the blue is not normally metabolizing. Those are the areas that could potentially generate seizures. So this is something that might be read as normal by a neuroradiologist. Of course, our neuroradiologist here often finds these things, but when we take that PET scan and put it on top, that helps give us even a clearer picture. So just because somebody's MRI is normal doesn't mean that they're not a candidate. All right. And then there's always checks and balances with the epilepsy surgery process. One of them is we don't want to cut out anything that you're using. So a lot of times as part of the evaluation, we'll do a functional MRI scan to see where language is involved. And so most people, even if you're left-handed, still have left hemisphere dominant language. And what the fMRI does, or the functional MRI does, is it looks at relative blood flow. So as your brain is involved in a task, it will actually direct more blood flow to that area. So we can put the patient in the scanner, the neuropsychologist then asks them a series of questions, and then we look for areas of relative increased blood flow during those times. And that tells us in generation of language, for example, that's where it is. So this is probably where Broca's area is when they're producing speech. And then finally, when they go to surgery, we also will monitor or take recordings from the surface of the brain. Sometimes we do this in the operating room. Sometimes this is part of a phase 2 evaluation where we put electrodes either on the surface or have depth electrodes into the brain, close up the skull, and then monitor on EEG. And I think our neurosurgeon, Dr. Fala, has a separate talk on this, as well as I think Dr. Nariai also talked about epilepsy surgery evaluation. So besides resective surgery, so cutting things out, there are other options. So vagal nerve stimulator is an outpatient surgery. This is an implanted device that's kind of like a pacemaker. It sits in the chest, usually on the left side, and there's wires up to the neck that then wrap around the vagus nerve. This is approved for children with focal seizures, but we also use it for a variety of other seizure types. It's about the same as trying a medication, a 50% chance of a 50% seizure reduction. However, some patients say that this is actually better tolerated than trying other medications. The newer model can even sense heart rate increases. So if a child is sitting there, suddenly they have a seizure, their heart rate goes up, it actually delivers a little bit of extra stimulation. And then on top of the stimulation already being present on and off continuously, you can swipe a magnet and give a slightly higher dose of the current. And now we can also adjust the different parameters, like for when the heart rate goes up or even while they're sleeping. And I often say, kind of treat this like a medication, but kind of don't, because some patients can take up to 6 months to see a response. There's a titration period, just like with medications. We don't turn it on full force because that can irritate the nerve. So we start at a low dose and kind of increase it up. And the main side effects are going to be related to the vagus nerve itself. So sometimes when it turns on, kids can feel sort of a vibration in their voice or get a little bit of a hoarse voice while they're talking, but generally it tends to be pretty well tolerated. Responsive neurostimulation is something that's newer. We're currently using for kids, although it's not approved yet. We use this in general for focal lesions in what we call eloquent cortex, so areas that we can't cut out, but we are also now using this for deeper targets, targeting the thalamus, for example, which is involved in sort of the circuitry of where seizures come from. So, so this is also an alternative when you're not a candidate for resective epilepsy surgery, but we are starting to look at this for use in things like generalized epilepsies as well. And this device actually sits in a carve out in the skull. And so that's why we have to wait until the skull is developed before you can be a candidate. And oftentimes that's closer to 7 years of age when the skull is fully developed. Another option for things like drop attacks or atonic seizures, or even now for epileptic spasms, we're starting to use this a lot, is corpus callosotomy. So there's a bundle of nerve fibers that are in the center of the brain that help the two hemispheres communicate with each other. And there's some thought that with these seizures, it probably arises from somewhere deep in the brain and spreads quickly. So maybe cutting that connection between the two hemispheres could help. This is done both open, where the neurosurgeon opens up the skull, and it's also done by laser, where the laser can actually ablate the fibers. And then deep brain stimulation is somewhat similar to responsive neurostimulation, but there's not a responsive part. It's more that it is a device that's constantly cycling. They also can choose different targets depending on where the seizures are coming from. Again, it's about 50% chance of 50% seizure reduction. About 15% of these patients become seizure-free. And then this often stimulates the thalamus, and we stimulate different parts depending on what type of seizure there is. Okay, So that, you know, was the information sort of in a nutshell, so that way we could have the last few minutes for discussion. But I just wanted to give some resources as well. So there's the ILE, so that's the International League Against Epilepsy, has an informational website here. The Epilepsy Foundation has a lot of information. And then there's also the Epilepsy Foundation of Greater Los Angeles. So these are good resources to look at, you know, different medications, different seizure types, where epilepsy centers are, you know, who can you reach out to for help, even support groups. Dealing with intractable epilepsy can overtake, you know, your whole life and can really consume a family. So there's a lot out here. Okay, so now I kind of want to just open it up if there's any questions at all. Hopefully that was, you know, it was a lot of information in a short period of time, but hopefully that was helpful. And if you don't want to unmute, feel free to also put anything in the chat. All right, so Alicia has a question. If a patient has seizure reduction from multiple meds, but never becomes seizure-free, would they still be a good candidate for surgery? And yes, that meets criteria. So if you're still having breakthrough seizures despite being on multiple medications, then depending on the seizure type, we might not be talking about resective epilepsy surgery, so cutting out abnormal areas, but we would still think about things like responsive neurostimulation or RNS, vagal nerve stimulation, or even DBS, depending on the seizure type. So, so it really depends on the seizure type. It really depends on what the underlying cause is, but it can, you know, there's options out there. All right, another question: when a patient is on a lot of meds but doesn't have seizure freedom and still a lot of seizures, can reduction of meds help seizures? There's been a lot of debate about this, about whether or not, like I hear on the parent end, of whether or not there may be certain medications that are actually perpetuating seizures or propagating seizures. And what we've really found is there is something called rational polypharmacy, where you are on multiple medications, but it is, but they're all working together synergistically. Of course, if you have one that is opposing another, then maybe it might not be helpful. So we have seen that where, for an example, you know, cannabidiol, Epidiolex, we still are learning a lot about how it affects the metabolism of other medications. And so I have had some patients that going onto it, their seizures actually got worse. And so sometimes it's worth actually reducing it, or going onto it, it increases the metabolite of clobazam, desmethylclobazam, so they become more sleepy. We have to reduce the desmethylclobazam. So it's not that the medication is necessarily increasing the amount of seizures, or that less is more. It's just you want to have the correct medication for your seizure type, and perhaps medications that work in different mechanisms, not that you're layering on multiple medications of the same type. So that tends to be a little bit better tolerated than just adding on as many medications as possible. So hope that helps. Yeah, and with Dravet, it's complicated, but it's a good thing we have more options available for Dravet, including, you know, Fintepla, and so hopefully that's, you know, as things are going and knowing more genetic diagnoses, we'll also have more targeted medicine where we can tell you, for this specific syndrome, this is the medication that's going to be helpful for you. And then if a patient still has seizures after surgery, would they go back to taking medications? Yes, not everybody is able to completely taper off medications. So sometimes they do need to continue on their medications, because we, you know, after 2 years, after 1 year post-surgery, oftentimes we'll try to reduce medications. And if we're not successful, they may have to go back, but maybe not, they're not on as high doses, maybe they're not on as many medications. So seizure freedom after surgery does not always mean medication freedom. It's a small subset of patients that are able to do that. If another question, if I've been considered to have refractory epilepsy, should I not try another medication? Should I go straight to another evaluation? Last evaluation was 2 years ago at an epilepsy center. So it's hard to really say, there is diminishing returns in terms of trying new medications, but I think it's worth sometimes reevaluating and seeing, because our options are constantly changing, and we are fortunate that we're in a time where new medications are coming out, new technology is coming out, new genetic testing is coming out, that it's worth revisiting things. So even I have patients who had whole exome sequencing like 10 years ago when it was still sort of experimental. I'm running sometimes their genetic testing again and finding things that weren't available 10 years ago. So it's always worth getting a reevaluation. Will there soon be new precision meds for patients with rare genetic epilepsies? I think so. So I think there is a lot of research that's going into specific etiologies for epilepsy, and whether it's genetic, whether we're finding also that sometimes you can have genetic mutations within your brain tissue and not elsewhere. And it's not until we actually do surgery and take out that area and do genetic testing on the tissue that we find out that you specifically have some mutation. And we are seeing that more and more, that when we have a genetic diagnosis, we have certain medications that work well for those types. And I think that the other sort of future on the horizon is being able to look at the specific medications for the patient and seeing how they metabolize them, or even having your cell line propagated in a lab, testing the medications on them to find out which one would be available. Right now, that process costs, like I've heard, $500,000 to $1 million per patient. So that's just not feasible outside of the research arena. But whole exome sequencing was also not available outside of the research arena, like when I was a trainee. So I think these are things that maybe 15, 20 years from now will have maybe a little bit of a better tools basically available to us. All right, anyone else? And we have 1 minute left. For a specific genetic diagnosis, I'm not familiar with that gene. So for this mutation, so oftentimes we have to look up what that specific mutation is, if there's other children who've had that mutation, if there's been specific drugs that have worked for them. And then, so that's why it's sometimes helpful to be able to publish these papers or belong to research consortiums, so we can all talk amongst each other and find out like what worked for us and tell other people, and then also what other people have experienced and what's worked for them. So, so that's something I think that we as individual providers often try to do for our patients. And what I recommend genetics consult to learn about treatment options. So yeah, so the geneticists have their own consortium sometimes in terms of who they talk to, and they might be familiar with other centers and things that they're doing. So including sometimes at the NIH, there's the Institute of Rare Diseases, and oftentimes they may have studies that are ongoing. So, so genetic counseling, especially if you want to know also about risk for future pregnancies, things like that, I think can be very helpful. All right, I think my time is up, but I hope that was helpful for everybody. And feel free to reach out if you have any other questions, and hope you have a wonderful day.